該。係，歡迎各位同埋你班同事，我唔讀一讀一。
Dr. Gold, I will introduce your team one by one. Today, we are on Chapter 2 of the Directors of Audit Report number 63. We have got a quorum already. Members responsible for this chapter, or the principal member responsible for this particular chapter is Mr. Alan Leung, who will join us very soon. Dr. Ko, you have already got a speech ready, so if you would agree to wait for 1 or 2 more minutes for Mr. Leung to join us. Well, actually, the Director of Audit did not recommend a hearing on this chapter. We want to do it out of our own initiative. And you have already agreed with the recommendations, and we'll take follow-up action accordingly. Mr. Alan Leung, welcome. You have 10 minutes. Sorry, Mr. Leung. I'll give the floor to the Secretary first, and then the Director, Dr. Chen, and then Dr. Leung, the CE of HA. Good morning, Chairman and members. First of all, I'm grateful to the Direct Audit for providing a very comprehensive and in-depth value for money audit in respect of the health and health services provided to the elderly by the Director of Health and the HA. There are many valuable input and suggestions. We agree with them. The DH and the HA would take active action to follow up the recommendations so as to further improve health services for the elderly. Before we respond to questions and comments of the PAC, I would like to stress that we would step up elderly health services to cope with the challenges of an aging populations. In the middle of this year, the HA launched a PPP project in Kwun Tong, Wong Tai Shin, and Tuen Mun so that hypertension patients attending the GOPC in HA clinics will receive treatment from private practitioners. And depending on the response, this public-private collaboration program can be extended to other districts. Although we are talking just about elderly service, hypertension patients, many of them are actually elderly persons. The public-private collaboration can also promote the concept of family doctor so as to provide better primary health care to elderly people. On the concerns expressed in the report, the Health Department would review the work of elderly health centers so as to improve the outreach team and also to look at its mode of operation and efficiency and the management of the coupon scheme. The HA will also try to shorten the waiting time of a specialist outpatient clinic and to enhance the transfer arrangements for the between the clusters, as well as providing more geriatric assessment services for the elderly homes. In a moment, the Director of Audit and the CEO of HA will be responding to the reports and relevant measures. Thank you. Dr. Constance Chan, you have the floor. Chairman, first of all, I thank you for allowing me to provide some brief response to the Director's Audit number 63 in respect of health services provided to the elderly by the Department of Health, and I'll also be talking about our follow-up action in response to the audit report. To tie in with the primary health care policy for the elderly in the government, the Department of Health provide health services for the elderly, including setting up an elderly health center in each of the 18 districts so as to provide a comprehensive primary health care to those over the age of 65, to encourage and promote self-care and the fostering of healthy living habits, and to make sure that their family members can take care of elderly family members so as to reduce the risk of disease and other disabilities. Second, we have 18 elderly care outreaching teams to serve elderly living in the community, and also to provide training to carers and home staff so as to equip them with the latest skills and knowledge. And also through the elderly health care voucher scheme, we promote primary health care to help the elderly patients getting access to the suitable family members. And starting from July 2013, we have been in cooperation with NGOs to provide healthcare assessment for elderly people of the age of 70, or more than 10,000 elderly persons have been served through this program for preventive care and to encourage the provision of community services by NGOs. With an aging population, we believe the demand on primary health care by the elderly would just go up and up. We would make reference to the Director of Audit's recommendations and reviewed our strategy and capacity so as to shorten the waiting time for elderly people to get registered as members of elderly healthcare centers, and to shorten the waiting time for receiving assessment, and also to learn from the experience of the elderly healthcare assessment pilot scheme. We will review the paramedical counseling services provided to elderly healthcare centers, and to look into ways to reduce the difference in waiting time of different centers, and also on why some elderly service recipients have been absent from such counseling sessions, and so as to make improvements. We also review the outreaching service of the elderly service, and also to tie in with the work of the PIC and the findings of the audit report to improve our services for the elderly. Dr. Chan, well, the Director of Audits have made a series of recommendations on HA's elderly health service. I will respond briefly to the recommendations and our improvement measures. We strive to provide quality health services to our citizens, including elderly citizens. We understand the concern expressed by the Director of Audit and the community on the waiting time of specialist outpatient clinics. In view of the recommendation of the Director of Audit, we will take further action to improve the waiting time. First of all, we will enhance primary health care so as to make sure that those who are stable and not suffering from serious complications can be handled by family medicine and general outpatient clinics. We are going to improve more manpower by employing part-time workers to enhance the staffing level of specialty outpatient clinics, and some clusters will also provide a subsidy as a temporary measure to improve the capacity of specialist outpatient services. We're also going to try out public-private collaboration, especially for specialties with greater demand, but the cases are not urgent. so as to address the manpower shortage problems. To enhance transparency, the HA has uploaded to our website the waiting time of 5 of the 8 major specialties. In 2015, we are going to provide information on waiting time for the remaining 3 specialties. Within our clinics, we're also going to display comprehensively and presented the information on waiting time in a consistent manner so that patients can make informed choices on their caring plans. To address the difference in the waiting time, the HA launched a referral system for specialist outpatient clinics between clusters. We cover ENT, gynecology, and ophthalmology. The patients use this for different reasons. For example, easier transport, shorter waiting time, and personal preference. We're going to extend this referral system to other specialties, provided that the clinical conditions are suitable. To enable more patients to have specialist outpatient clinics, we would make use of statistics and seasonal fluctuation and manpower situation, and allowed more bookings than the capacity would otherwise allow, so as to make the best use of those of patients who do not turn up for the assigned slots. We would also coordinate the booking system of different specialties so as to improve it and enhance it. We have extended our community geriatric assessment service recently to cover more elderly homes. As at March 2014, the coverage is 638 elderly homes, or 89% of the total. We'll continue to review the mode of service of this assessments team service so as to enhance the quality of service in community elderly homes, and we would provide more service at suitable locations for residents of elderly homes. All in all, we are grateful for the comprehensive review conducted by the Director of Audit. We'll accept and we'll follow up on the recommendations so as to further improve health service for the elderly. Members, do you want to declare your interest now? If not, we can proceed. Mr. Leung. Chairman, the PAC, Public Accounts Committee, is very concerned about Chapter 2 of the Directors of Audit Report, number 63, and that is elderly provision of health services for the elderly, because by 2031, 1/4 of population will be over the age of 65. So it's a ratio of 3 to 1 in terms of young and old. So we are facing a tough challenge ahead. I've noted that in his opening remarks, the Secretary for Food and Health says that the administration would improve elderly health services to cope with the aging population. But is this just lip service? That's the answer we have to find out today. From a value for money point of view, providing health services for the elderly in Hong Kong is the responsibility divided between the Department of Health and the HA.
The Department of Health spent about $1 billion a year, and through the 18 elderly health centers and 9 NGOs, and 18 visiting health teams. And also, the Elderly Healthcare Voucher Scheme provides healthcare services for the elderly. So basically, there are 4 initiatives totaling $1 billion a year for providing healthcare services for the elderly. The other service provider is Hospital Authority. In 2013-14, the annual expenditure was $50 billion, 46% of which, that is close to $25 billion, was spent on elderly healthcare services. The HA has 7 HA clusters, the public hospitals, and 73 general outpatient clinics and 47 specialist outpatient clinics. And the healthcare services are provided. In this audit report, what is in front of us is that, be it the Department of Health or the Hospital Authority, the services they provide can be improved in terms of their efficiency so as to better utilize resources for the benefit of the elderly, so that they can receive more appropriate care that better suit their needs. So in a moment, in this PAC hearing, we're going to conduct a hearing following these lines. So before I begin, perhaps I should ask Secretary first on his opening remarks. Just now he emphasized that the administration will step up services for the elderly. However, let's look at para 2.6 of the audit report. If you read para 2.6 of the audit report, between 2004 and 2013, the elderly population increased from 831,000 in 2004 to 1.049 million in 2013, but the 18 EHCs, elderly health centers, provided less than 40,000 health assessments a year to the elderly. The capacity has not been timely expanded to align with the growth of the elderly population over the past 10 years. So it's a question for Secretary or the Director. Why did we not have any expansion in the EHC's capacities to tie in with the growth of the elderly population? Because Secretary, in his opening remarks, said that the administration will step up elderly healthcare services. So it seems to be lip service. Secretary, are you able to answer these questions? Thank you, Chairman. Thank you for the questions. Let me give my take on the questions. If necessary, I will defer to my colleagues to supplement my answers. I have 3 points to make. I'm not going to object to the points raised by Mr. Eleanor about his observations on our elderly population, and I think Mr. Leung has been asking whether the capacity has caught up with the growth of the elderly population. First of all, as far as the policy direction is concerned, one of the major challenges for healthcare services is the rapid aging population. Of course, we attach importance to the health of our elderly people, so we place much emphasis on enhancing healthcare services for the elderly. Or to put it more correctly, how we can make our healthcare system provide sustainable and cost-effective quality healthcare services for our population, with particular focus on the elderly. However, we must also understand that as far as the whole public healthcare system is concerned, is funded by public money. From the fiscal perspective, we can enhance services to the extent according to the allocation of funds from the administration. So we may not get funds for what we hope to enhance. That depends on the government's allocation of resources. Second point, as I mentioned just now, first of all, we need to consider how the overall healthcare system's efficiency can be enhanced so that the whole system can have sustainable development. I think this is a very important point. With an aging population, we need to review the existing public healthcare system because it is a public safety net for all, and the majority of resources we get are from public funds. So with an aging population, an increase in population, and also taking into account technological advancements, also the public's increasing expectations on public healthcare services, we're facing a major challenge. Therefore, very recently we have come up with another initiative on top of the existing initiatives in order to strike a balance between public and private healthcare systems so that the double-track healthcare system in place in Hong Kong can be fully utilized, so that resources from both public and private sector can be fully utilized to provide sustainable healthcare services for Hong Kong people. I won't go into details anyway. Revamping the healthcare system as a whole is also important. Apart from looking at capacity, we also need to consider efficiency and sustainability of our system. Having said that, we should not focus on a particular type of service, because apart from the 18 elderly health centers, and consider how the capacity can be enhanced, we have introduced new services which may give better efficiency over services provided by the DH or the HA, because as you understand, in recent years we have introduced the Elderly Healthcare Voucher Scheme, EHCVS. On the one hand, we'd like to improve health services for the elderly and enhance the HCs. We've also introduced the voucher scheme. Elderly patients can choose to receive services outside the EHCs based on their own conditions and the needs, because under the voucher scheme, elderly patients can have more choices from the private sector, covering a wide scope from dentistry, Chinese medicine, and other kinds of healthcare services. It also covers preventive medicine and primary healthcare. And these initiatives go parallel, so I hope members would not just focus on a particular type of service, whether its growth has been in line with the growth of our population, because at the same time we've also introduced other forms of services. Thirdly, primary health care is very important in Hong Kong, and this is not only the responsibility of the administration. In terms of service capacity, for secondary care, that is patients requiring hospitalization, HA services account for 90%, or somewhat 88% at the moment. So HA plays a major role. Yesterday, we proposed the HPS, Health Protection Scheme, and we suggest that the private sector should take up a larger share so as to relieve overcrowding in the public sector and to shorten the waiting time. For primary care, however, the situation is the opposite. In fact, 70% or about 70% of services are provided in the private sector, and patients rely on their own resources. Only 30% of the services are provided in the public healthcare sector. That means in the same vein, can the government take up the sole responsibility of providing primary health care in Hong Kong? Because for the 5.2% GDP ratio, government healthcare services only account for 2.5% or so. That means for other remaining expenditure, it's coming from the private sector. So it's not necessarily the case that we can catch up with the increase in population by expanding our service capacity, in particular in the case of primary care. The Department of Health plays an even more important role in this regard. And the purpose of setting up the 18 EHCs is to introduce the new way of developing primary healthcare services. That is, the 18 EHCs do not aim at meeting the needs of elderly patients highly subsidized by the government. Instead, they aim at setting up a primary healthcare model with guidelines prepared by experts so as to direct a new service model for elderly patients in the community. and it is hoped that this new service model can also be introduced in the private sector. I don't have statistics at hand, but we note that in the community, private clinics and NGOs are actually following this direction and learning from this primary care model in their provision of services. I also visited some community centers providing primary care for not just elderly patients, but other patients in the community, operated by NGOs, and their model is getting more and more similar to the service model provided by the Department of Health's EHCs. So I hope members of this committee would better understand that in terms of primary care, what the government's policy is. Of course, we try to enhance its capacity where public funds are available. At the same time, we also explore different service models so that apart from EHCs, our elderly can also seek the same or similar services in the private sector through the use of vouchers. Thirdly, we'd like to be in the lead. We should not expect that public money can provide all the services our population needs. Thank you for explaining so comprehensively your policies. I'll try to be precise. But about the audit report number 63, it's a value for money audit. As you have accepted all the audit's recommendations in the report about what you said just now, it's somewhat different from the recommendations that you have accepted. But maybe my colleagues can follow up on it for the purpose of our report. And we agree very much to the suggestions, as you said just now. However, you must also address the issues arising from this report. Yes, what would you like to supplement? Chairman, thank you for a reminder. First of all, I understand that questions coming from this BAC are quite focused, and these questions arise from the audit report. But in response to Mr. Leung's question on whether the government structure alone can provide all the services to meet the needs of an increase or of an expanding and aging population, I need to explain the government's policy. If there are specific questions that I cannot answer, I'll defer to the department heads. Mr. Leung. Thank you, Secretary. For sharing with us his ambitious plan. But if you go to Yau Ma Tei and Wan Chai and consider the elderly people waiting for the first elderly healthcare assessment, you may not feel relieved after hearing what I'm going to say. Let's say we spent $1 billion on the Department of Health initiative, and then these elderly people needed to wait for 9 years, 6 months in Wan Chai and Yau Ma Tei on the waiting list. In terms of efficiency, in terms of whether these patients really get the services that they need, I hope the Secretary will understand.
The Secretary has this huge plan. He's going to implement it. For those who are waiting for the first time or follow-up assessment at elderly health centers, perhaps they won't be with us anymore. So you may have a huge plan, but you still need to handle the matter in front of you. That's just what I want to point out. Thank you, Mr. Low. I do understand, but perhaps what I said just now was too lengthy. I urge you to pay attention to one point in the middle. That is actually a reply to Mr. Lowe's question. With increasing number of elderly people, whether the existing services can satisfy all their needs, there is a gap, and that's why the waiting time is longer. If we choose different ways to provide the services, or which method is more straightforward, well, perhaps we have different considerations. We have to provide more services at the EHCs and provide more manpower, then perhaps we need to explore a different model. And that is the voucher scheme. During the pilot run, it was only $500, so the impact is quite limited. But today, we are increasing it to $2,000. Because we are providing fundamental services to elderly people, $2,000 will provide greater flexibility, and they don't need to queue up only at one place, because we need time and planning to expand the scheme. And now they have the option or the mandate to use the $2,000 in the community to obtain similar services. So we partially respond to their demand. Thank you. In Chapter 2, Part 4, we will talk about the management of the voucher scheme in a minute. The PC is quite concerned about that. I don't suppose you want to encourage jumping around, so let's complete the second part first. We want to see if this is really good use of funding allocated by the LegCo. I would like to ask you to refer to page 12, Table 2 in the Chinese version. According to the results of audit, different centers for first-time assessment and follow-up assessments. Perhaps the witness can first refer to second and third column. Among 18 EHCs dealing with subsequent assessments, the figure goes way beyond the first-time assessment. If you combine that with page 13 of the Chinese version, after paragraphs A and B, it says that first-time assessments are important because an analysis of the 38,000 odd elderly health assessment cases of 2012 indicated that 32% of the 5,000 odd elderly were found to have medical conditions in their first-time assessments, whereas only 7% of the 33,000 odd elderly that had new medical conditions in their subsequent assessments. That is para 2.13 bracket B. So I would like to ask you, does it show that the EHCs, in terms of allocating resources on first assessments and subsequent assessments, perhaps there's a lack of balance? If you place more resources to do first-time assessments, perhaps it is more effective in serving the elderly people. Because with proper follow-up, there will be less newly added medical conditions. Otherwise, there will be more serious problems. So shouldn't we inject more resources into first assessments? And afterwards, there's no need to have so much going into subsequent assessments. I will ask the director to respond first. For first assessment and subsequent assessments for each EHCs, there could be different factors affecting their work. We agree that there are many problems identified at the first-time assessments, and later on, the level of problems would diminish. First-time and subsequent assessments for different EHCs will be based on the queuing time and the ratio. And we're talking about 69.1% to 84.5% of the elderly, whether they do return to register. In every district, there would be frontline people providing their views, but we do agree with the audit, and we will more seriously look into allocation of resources. And it also touches upon treatment services. It depends on how many people actually return to obtain such services. In some of the centers, if the ratio is lower, actually 7 of such centers have provided 1 to 2 more assessments for treatments. And beginning from June, we added another 2 centers to the list so as to strike a better balance. Well, a lot of time has been taken up by the secretary, so I will give you some time back. I've heard from the director his reply. Actually, if you refer to table 2, it is in fact quite disturbing. As I have said, in Yamate and Wanchai, the time needed to clear the queue, number of years, 9.6 years. So it doesn't matter what huge plan you have to deal with the immediate issues right away. The director said they will be flexible in moving people around and using the money in different manners. 18 centers on a daily basis, how much services are provided. There should be more resources going into first assessments. But still, I'm looking at 9.6 years waiting time. It is very appalling. For Yau Ma Tei and Wan Chai districts. That is a waiting time at their EHCs. So every day you are providing 1 to 2 additional quotas. That is nothing compared to the overall picture. Are there other ideas or arrangements that could assure the PAC that elderly people will get better services? Director, you have to wait until you are 65 until you are classified as an elderly person. So you have to wait until you are 76 before you have the chance to enjoy these services. Can you explain? Allow me to provide some background information. The DFH well, actually, among the 1.034 billion, the EHC will take up 134 million, and the voucher scheme will take up about 846 million. So we will always identify new ways to satisfy the needs of the elderly. In 2014-15, concerning EHCs, we have already allocated resources to set up this clinical team. So in the first quarter of 2015, recruitment will be completed and the services will be commissioned. And another team will be set up for Wan Chai, where the queuing time is longer. As for Yau Ma Tei district, other than making reference of the length of the waiting time, we also need to consider if it is physically feasible to add any rooms or facilities. So the new facilities will go to Lake Yun and Wan Chai. I would like to ask the director. Well, there are 18 such EHCs. Have you scientifically assessed how much resources can be reallocated for each one of them? If you look at Yau Ma Tei, Wan Chai, 9.6 years, or you have to wait from 65 years of age to 75. More than 800 million has been injected into the voucher scheme. So if you look at table 2 and look at the waiting time, is there any mechanism for those who have already obtained the voucher? And they can go to the private sector to obtain the services. And then they stop waiting on this queue for EHC. For services provided by the DFH. If you don't have such a mechanism, are you going to set up such a mechanism so that the figures can be less appalling? So that it is not so worrying that you have to wait for 9.6 years? If they are satisfied by the services provided by the private sector, shouldn't they leave the queue so that the figure here can truly reflect the reality? Director? the mean waiting time has been followed up upon on a regular basis. For example, in 2007, the mean was 38.3. Seeing the increase, the Department of Health assessed the situation, and in 2008, we streamlined the questionnaire and also simplified the procedures for assessment. We were able to gradually reduce the waiting time. By 2011, the mean figure was 10.4. So with internal deployment and streamlining, we shortened the waiting time, but still there was over demand, and later on we saw an increase again. By 2011, it was 10.4, and the next year 12.3 months. Seeing that increase, we started launching pilot schemes to try other models to improve the figures. In 2012, we also fought for more resources. So for 14, 15, 15, 16, 2 new clinical teams would participate in providing the services, where the voucher users can be assessed in a way that whether the waiting list can be shortened. The computer system only sees what services they obtain from which institution, whether it is a chronic illness or acute illnesses, but the computer system does not allow us to match these people with the people on the waiting list because it's too complicated. I don't have any new questions, but I would like to ask the director to submit a paper to explain clearly. There are 18 EHCs according to your understanding. For the resources not yet engaged, how can you redeploy the resources to achieve high level of efficiency? Can you provide the paper? Because I was listening to you, but I don't really follow you. Director? Chairman, clinical teams are led by doctors. Sometimes people coming back for follow-up checks or treatments, well, the ratio is not 100%, and the figure is different from district to district. So there would be more subsequent assessments. We'll try and see if we can provide a follow-up paper to Mr. Leung. I want to be able to finish the report. You are facing this problem, and can we say that from the Director of Health, we obtained the following information, and after analysis by the PAC, we believe that this new arrangement or reallocation of unused resources among the 18 AHCs can address the issue to a certain level. I hope I can write something like that. Otherwise, it's not satisfactory. Director, do you understand? We have to write a report. Chairman, every AHC only has one doctor. So how many patients can be seen by the doctor for first time or subsequent assessments? Well, you can see that it is basically the same. It depends on how he allocates his time. But the situation is different from district to district.
Well, if you look at Wan Chai and Yau Ma Tei, where you have a bigger elderly population, as Mr. Leung has put to you, maybe you can do something about that. Instead of asking the elderly in Yau Ma Tei and Wan Chai to wait for 9.5 years, if you give us a paper, and we can take your advice and write it in our report. Mr. Kenneth Leung. I also want to refer to Table 2 and Table 4. Table 2 first, page 12 in the Chinese version. If you look at the total number of assessments, it's 2,000 something. I think you have exhausted the entire capacity of the EHCs. And if you look at the number of years required to clear the waiting list, the lowest is Yunlong, just 1 year. The highest is Wanchai and Yaomate, 9.6 years. And this takes us to Table 4, page 15 of the Chinese version. Here we have another set of figures. The medium waiting time. There's a big correlation between the order here and that in Table 2. Wanchai, Yaomate, medium waiting time. For Wanchai, 27.8. Yaomate is 25.4, and the lowest is Yunlong. I have a question here. In your planning, you should first and foremost look at the demographic data instead of having one EHC in each district, staffed with one doctor, and I think that is the optimum utilization of your resources. It's not scientific to have one EHC for every 500,000 or 600,000 people. I think, Dr. Koh, you are responsible for the financial management of this program. You must know what I'm trying to get at. You have to look at the number of people in need of such assessments. For example, if there are more elderly people coming from grassroots, of course, the health conditions of the elderly are relevant, and it's also correlated to whether they are middle class people or grassrooters. So maybe in Yaomate, you need to have 2 doctors, or you need to expand the center in Yaomate. Maybe overall you don't have the increased manpower for the 18 districts taken together. If for the 2 districts you have the waiting time of 7 to 8 months, you may wish to combine the 2 centers and the resources for them. In the long run, you need to do some assessment. Do you have a plan for such an assessment? Or are you saying that I have utilized all my resources and I can only rely on the elderly health voucher scheme to provide some relief? Director? Well, we agree that the medium waiting time differs in different districts, and this is not satisfactory. We'll look into ways and means to address the concerns expressed by the Audit Commission. Well, can you be more specific? You are going to look into this? How long would that take? Are you going to compile a report for that, or for us? Or will the report be made available to the public? Well, what are your plans? Well, the study will be carried out by our colleagues responsible for elderly services and the consultant on geriatrics, and our one assistant director will be involved. So one of the possible options is to provide additional assessment sessions for the EHCs facing higher demand. Well, that's about the supply side. But what about the demand side? In Yamata, you have one EHC, another one. In Yunnan, you have one EHC. Have you looked into your clientele? And that is the demand, quantitative demand in each district. Would there be a quantitative analysis? Well, your approach is short-sighted. Well, the waiting time is more than 20 months, and you want to provide more doctors. But you must not ignore demographic data in the long run. Perhaps the Secretary can respond. Well, I'll let the Director to respond first. Yes, we're going to look into that. The policy on setting up EHC is to have one EHC in each district. And the policy doesn't aim at providing services to all elderly residents in the district. It serves as a proponent, a model for providing primary health care. But because of the increase in demand, we do admit that there's a need to look into ways and means to improve the service. Secretary. Well, I think I have nothing to add in accordance with your procedure. I will be talking about things at the macro level. We are very serious about this. I think we shouldn't assume that this is the only mode of service delivery, as pointed out by the Director. We shouldn't start off with this assumption that this would satisfy the needs of all elderly residents. Therefore, we'll come up with another mode of service, which is more flexible, which can serve and meet the needs more effectively, and that's also an empowerment model. Under this mode, we are not able to tell whether the elderly people have made use of the voucher scheme to seek services. And maybe we should ascertain whether the elderly have utilized the voucher scheme extensively. Have they been registered under the voucher scheme? And do the doctors and healthcare facilities in the district been participating in the voucher scheme service? We don't know whether the elderly in question will just sit there and wait for the EHC service for 9 years, or they may be utilizing their own resources or resources under the voucher scheme and get the problems solved, and at the same time they don't mind putting their name down on the waiting list. The elderly may have other means to satisfy their service needs, and they just don't mind to have their names still kept on the waiting list. But I don't think it's a good idea to exclude those which have already utilized the voucher scheme. Primary health care should be multi-faceted. One of the major reasons for setting up EHC is to guide the development of a service delivery modes. Many voluntary agencies and private practitioners have made reference to EHC service in planning and in the provision of their primary healthcare services. And looking at the Audit Commission's recommendations from the point of view of value for money, of course, if we have more resources, the resources should be invested in districts where the demand is higher or the waiting time is longer. Well, the Secretary is saying that some elderly people may have other resources which, to seek services. They may have access to other services, and they don't mind putting their names in the waiting list. That may be one of the reasons why we have such a long queue. Mr. Alan Leung has referred to you page of the service recipients. Only 7% were found to have new problems in subsequent assessment. And among the 33,860 elderly, 7% had new medical conditions. But for first assessment, among the 5,067, 32% had medical conditions in the first time assessment. The Kowloon City EHC has allocated only 4.5% of its health assessment session to first-time assessment, while the Lake Yuen EHC had allocated 27% to first-time assessment. If you look at the outcome, maybe some of the assessment sessions, more assessment sessions should be allocated to first-time assessments. Dr. Koh, after the first-time assessment, the elderly may have access to other services. For example, those services offered by NGOs, or they may have utilized the voucher scheme. Some elderly people don't know where to turn to seek services. And after first-time assessments, they know what they should do, what they can do. So the elderly would have access to a lot of information because of first-time assessments. And now we have a big difference between the allocation of first-time assessments among different EHCs. Perhaps you can account for the difference here. We're very concerned because you have already accepted the recommendations of the Director of Audit, and we have to take follow-up action, and we have to be accountable to elderly people in different districts in regard to the service levels. I understand, Secretary, you want to look at this from a higher level, but I hope we will be able to give answers to the elderly with regard to service provision. So in addition with the top-down approach that you prefer, we have to also look at the bottom-up approach, because they do have strong views. The elderly should be satisfied for needed services. Yes, maybe we don't have much time, you don't have much time, you have other businesses to attend to, but I think you should explain to the elderly why the waiting time is so different. The range is from 1 to 9 years. We want to find out the reasons behind. So please don't just look at all these issues from a macro point of view. Secretary, Well, I'm not in a rush. I have reserved sufficient time to work with the PAC today. All my comments are based on the acceptance of the Director of Health's acceptance of the recommendations. And yes, we can certainly look at the ratio between first-time and subsequent assessments, and the mandate of EHCs is not confined to assessments. And the ratio of finding out medical conditions varies from district to district. And then after the assessment is done, the elderly can choose where to get service or whether to use the voucher scheme for services. I understand that the variation is on the high side, and the Director has agreed to look into that. Further questions, Mr. Kenneth Lau? Mr. Paul Chair, the two colleagues have talked about the waiting time and the EHCs in the different districts and their services. According to the Director, if I understand her correctly, other services such as the voucher scheme might mean that the waiting time is not as serious. Although it looks long, maybe they have access to other services, and the long waiting time is not as big a problem. But the Director doesn't know. She says she doesn't know. How the different services would sort of providing the substitute services. Maybe can the Secretary or the Director provide a recap to see if my understanding is correct or not? Well, that's how I put it. I want to point out that if we look at Table 2, and only Table 2, I hope we won't assume that all elderly residents and all their needs for primary health care will be met by EHCs. I actually don't know. That those who are subject to the 9 years of waiting time, but that's the nominal figure, and whether they have access to other means to satisfy the healthcare needs, such as the voucher scheme. That's what I have said. Director, do you want to add anything? No, I have nothing to add. Maybe I need to refer to other parts of the report, because mention has been made about the voucher scheme. Well, yes, that's okay. There's no way we can avoid Part 4 on the voucher scheme, since the Secretary has already referred to it. We know that you have different services apart from those provided by EHCs.
3同4點。
Paul, thank you, Chairman. Let's look at para 4.3 and 4.4 about private service providers and the registration situation. If I understand the report correctly, for private healthcare service providers, be it Western or Chinese medicine, 93% of the voucher claims were made by private healthcare providers. Yes, the figure is correct. Most of the patients visited Western medicine or Chinese medicine practitioners. We don't have any figures in relation to the nature of these services. I reckon that the majority of these medical practitioners did not provide assessments in a way similar to the assessments provided by EHCs. Now, our analysis includes whether it's a treatment or curative treatment for acute or chronic diseases or preventive treatment. We don't have any analysis as to whether the treatment is similar to that provided in EHCs. Well, at least I can say that the treatment given by practitioners wouldn't be as comprehensive as a comprehensive assessment. Our system did not capture such data in detail. We only knew that it's not preventive. Now, Director seemed to suggest just now that the HCVS would explain the waiting time for each C and that the situation is not as serious as the figures would suggest. In fact, for the Western and Chinese medicine practitioners, well, many of them, only if they provide comprehensive physical examination or assessment would your explanation be plausible. Using the EHCVS is one initiative. We also need to work more from the feedback given by frontline staff. Most of the elderly patients would like to receive treatment rather than assessment. Yes, you may be correct. So my theory of 93% of the voucher claims made for medical treatment shouldn't address the issue of long waiting time for EHCs. Secretary. Chairman, I can only say that I don't think we can draw this conclusion because for Chinese medicine they place much emphasis on prevention rather than cure. So it's really difficult to draw this conclusion. I don't think I can answer Mr. Chair's question. Thank you for confirming my understanding. This is my understanding. Chairman, I'd like to bring out another point. Just now, Director mentioned that we have VHTs visiting health teams. So let's see if my understanding is correct. For example, in para 3.2, it sets out the VHT's work. If I understand correctly, 90% of their work have to do with healthcare promotion. As far as comprehensive assessment or integrated assessment is concerned, it only accounted for 6%. Director. For the integrated assessments on page 28 of the Chinese version, it refers to the VHTs attending residential care homes to check the facilities and the work of health, disease prevention, anti-slippery efforts made by care homes. Alright, thank you for your answer. It seems integrated assessments have nothing to do with medical treatment for elderly. So, in the course of the VHT's work, there is nothing about physical examination for elderly. Right, because visiting health teams work is about educating and guiding residential care homes on the care for the elderly. It's not about giving assessments to elderly people. Maybe we can look further into that. But on the face of it, expanding your VHTs in terms of the number of teams and the team members cannot address the issue of a long waiting time for EHC assessments. In 2014-15 and 2015-16, we are increasing manpower for EHCs, not VHTs. But I stand to be corrected, but just now you mentioned that the problem could partly be addressed by expanding the VHTs. No, that's for the clinical team and EHCs. So what about the division of work? One of the teams would be deployed to Lek Yuen EHCs in 2015-16. Another team will be deployed to the Wan Chai EHC, and they'll be tasked to carry out the work of the EHC. That means first-time assessment and follow-up treatment. So Wan Chai is one of the most disastrous areas. So thank you for placing your effort in Wan Chai. Apart from a long waiting time, and let me have some time to refer to the table. I'm referring to the Chinese version, table 10. That's in page 42 of the English version. Ratio of EMPs to eligible elderly. I can say that for Wan Chai is 1.145. It comes the final 3 or 2. I'm sorry, let me put it another way. That means the ratio is it should be higher instead. So does it mean that in other districts there are other healthcare services available, and that the long waiting time may not truly reflect the plight of elderly patients? Secretary. Now, in terms of demand, waiting time, or participation rate, as the figures present, there are a lot of factors affecting the result, including the elderly population in the district, and as the other member put it, other healthcare services provided by HA and NGOs, the choices they had, and to some extent, the figures also reflect the characteristics of the district. For example, in an urban district, the elderly health center in the district might be easily accessible, comparing to a remote area in the New Territories. Even if we place the EHC in the most popular spot in the district, some elderly people may not find it convenient to go there because of the transportation network. So I really can't answer your question. The HA in 1997 undertook that a review would be conducted in relation to the checks and balances. I mean, in relation to an assessment system, I believe that's about a comprehensive assessment. Director or Secretary? Maybe I'll defer to Dr. Leung. I want to ask Mr. Chair about the assessment in 1997. What are you referring to? Are you referring to the community geriatric assessment teams? I'm referring to 2.15. About HA providing such services through its general outpatient clinics. At the meeting of the Ledge Coast Panel on Health Services held in 1997, the Director of Health indicated that the two systems would run in parallel during the initial operation and undertook to conduct a review at a later stage of the operation of both systems. Well, in 1997, the DH set up the EHCs, and a review was conducted at that time. And for GOPCs, we don't provide curative treatment to elderly or assessments to elderly patients. So you think it's not necessary to conduct any review, and you can let the EHCs do all the work? In 1997, GOPCs were still under DH, and HA took over GOPCs from DH in 2003. For GOPCs, we provide treatment for chronic patients. We also have risk assessments, for example, diabetes. We conduct risk assessments, follow-up education, and empowerment exercise. So from then on, the two service units had been adopting different models. EHCs provide curative treatments to members. For us, we give quota discs to elderly, and we don't focus on a particular age group because some elderly people are quite healthy. Paul, following this question, because I need to ask the following, because the conclusion of the audit has come by after in-depth investigation. So I don't quite understand that originally the two systems would run in parallel, but now you said that this is not the case, and then the audit's conclusion, in fact, there was no such parallel system in place. That means 2.15, you're still referring to the not conducting a review. 2.15, any further explanation? Thank you, Chairman. I think in the beginning of 2.15, it says the EHCs provide curative treatment to members. We're talking about curative treatments, not assessments. That means the follow-up part. Okay. So HA also provides follow-up services. (2.15) First sentence. Maybe Assistant Commissioner can supplement. From 2.15 to 2.17, we're talking about curative treatments. The EHCs provides health assessments or physical examination in the morning and treatments in the afternoon. We believe that the curative treatments given by EHCs are similar to those provided by the HA. That's why we focus on the curative treatments here. It has nothing to do with the first assessment or follow-up. Thank you, Assistant Director, for your clarification. But even for the curative treatment part, the HA once undertook that there would be a review, but no review was conducted. So 2.15 is correct. Next, Alan. Thank you, Chairman. Chairman Secretary says that we should look at the whole picture and don't just focus on the specific. But the point is, we can't see the big picture here. And we're still on part 2, elderly health centers and the services provided by DH to our elderly people. Director seemed to be telling us that we should not just look at those staggering figures, waiting time in tables 2 and 4, because elderly also receive some sort of assistance under the voucher scheme. I recall that a few years ago, when the pilot scheme was first rolled out with a voucher amount of 250, the administration, in its funding application, mentioned that there would be an e-health system which should be able to help assess whether the policy objective has been met. So my recollection is that elderly patients could make use of this scheme to establish a closer tie with the private medical practitioner that they opt for, and then Secretary also took the opportunity to promote the healthcare reform report published yesterday. So we're talking about closer and more efficient collaboration between the public and private sector. But the point is, when the PAC is to compile a report on the audit report, we also want to see the big picture, as Secretary put it, and that in fact this whole system could meet the needs of our elderly. But the point is, we don't have the statistics. So, Secretary, does the e-health system do any help? Can it give any help? If so, please give us some figures so that we know whether it's effective or not. Because if the pilot scheme or the pilot program is successful, you're going to regularize the program so that there will be further collaboration between public and private sector, so that elderly people can receive assessment as well as curative treatment. But now, if at this stage what we hear is just lip service, how can we write this report, and how can we allow a longer term recurrent funding for the government to implement this initiative? I don't know if I'm missing anything. Secretary. Let me try to understand Mr. Leung's question. You're asking how, in the long run, we can provide primary healthcare services that can meet the needs of the public. Perhaps my question was a bit clumsy. Let me be a bit more specific. Now, the Secretary just now was saying that we failed to see the big picture, and we should also consider Part 4, the elderly healthcare voucher scheme. So my first question for Secretary is this. Do we have anything quantifiable that can show that the voucher scheme could make up for the services for the elderly provided by the HCs? Because just by looking at Table 2, the situation is really astounding. But Secretary said that we should not just look at Table 2. In order to see the big picture, we should not just focus on the specific. So my question is, are there any figures that can allow the PAC to see the whole picture? So specifically, any figures you can or data you can draw from the e-health system to support your argument. Let's say some elderly people may be in the EHC's queue, and then their needs were then met by the services provided under the voucher scheme. Secretary, I think in the system, what we know is the elderly people who have registered for the voucher scheme, because once registered they'll be given an account, and then once a year at a specific time, money would be deposited into the elderly's account, and we also monitor the service the elderly person gets from a service provider, and how much will be deducted from the account.
So for those above the age of 70, that's where the threshold is for the voucher. How much are we giving them? And how many people are in the target group? How many of such people have already registered and have an account? And what is the usage rate of the voucher scheme? So if you refer to Table 2, in different districts, there are EHCs, and they are on the waiting list. We may not be able to match the identity of such people. How many have already registered for the voucher scheme, and whether they are actually using the vouchers. We have to do a thematic study on the people waiting on the list. Well, the administration is promoting this, but when they respond to PAC's questions, they said that 800 million is spent on the voucher scheme, and that deals with part of the demand on Table 2. But the figures are lacking. If we are to write a report, we can only say at this stage that the Secretary explained that the situation is not as bad as it appears to be, because these elderly people are waiting for the EHC services, but they can be satisfied by private services. Nothing has been quantified, nothing is there to show that there is a basis to what the Secretary is saying. That is the problem. So are you going to ask another question for e-health system? Are you on a waiting list in a certain district? When they go see the doctor will have to register in the system. Are you going to ask the doctor to ask that patient if they are still on the waiting list? I'm not suggesting you should remove their names, but you should ask them if they still want to obtain the services from the HCs. As the controlling officer, you should have such an idea to grasp the figures and quantify the information so that you are accountable to LegCo, and at the same time you understand what is going on. So, Secretary, do you think there is such a need? If you do agree there is such a need, are you going to commission the Department Director of Health to do some additional work under e-health system? Secretary, we just want to obtain more information. We're not saying that we don't agree with you. If you don't have the information, just tell us, and you can provide the information later on. Chairman, I actually agree, but it depends on the director. Perhaps we shouldn't do this under e-health system, because that is a simple registration, input of money, and outflow of money. For those waiting at the AHCs, can we carry out an investigation concerning the waiting time? Can we see what are the medical services are they also obtaining? We're not just talking about the vouchers, because they are using their resources to see their own doctors or obtain services from voluntary groups. Or even under the HA, our clinics, they are getting their needs satisfied. Perhaps that is one possible direction. Secretary, if you refer to Info 4, e-health system, there are two purposes. 63/2/Info 4, page 8, about e-health system. Perhaps you can use that as some reference material. We commissioned CU Hong Kong to carry out assessment. That was March 2013, and we saw 32 people who responded, said that the scheme encouraged them to use private healthcare service more often. As for the e-health system computer data, we can also see that when the elderly decides to use the voucher, it is mainly for medical care. 69% of the claim transactions went towards episodic care, 21% for management of chronic diseases, 7% for preventive care. Mr. Leung asked his question, and we can only tell him that we understand 7% are for preventive care. But for the details of such care, the computer system cannot capture such information, and we agree we need in-depth assessment. In the middle of 2015, we are going to carry out a review on the voucher system. And in that process, because we have taken on board the audit's report concerning the use of voucher schemes among elderly people, we will see how we can grasp more information and data to adjust our policy. We are not talking about the e-health system, which mainly focuses on accounting figures. It may not be a very good analytic tool. We can conduct a separate survey to do the review work. So this paper indirectly explains that the survey conducted by CU Hong Kong already offers quite clear information. So for part 2, waiting time, perhaps that's the information they are able to provide at the moment. The director seems to agree with the secretary in terms of collecting relevant and timely information and data. We can then try to understand part 2 of the report concerning those who are on the waiting list for EHC services and understand what other services they are using. It seems that the director supports this idea. So we can say in our report after this public hearing between the PAC and the Audit Commission, this is the result. So my 15 minutes is up. Perhaps the next member, Chair, I myself and Mr. Leung have been asking for the information that will help us understand the whole picture concerning the waiting time. Would like to reduce the level of inconvenience for elderly people. Concerning the elderly health assessment pilot program 2.28. If I understand correctly, this is done in 2 phases. It is now ongoing. It's been going on for about 1 year. But if you look at the effectiveness, the target would be to include 10,000 elderly people by mid-July. Only 2,200 odd elderly people have enrolled. Is that correct? By the time this report was prepared, that is correct, but I can give you the latest figure. By December this year, about 5,000 elderly people have enrolled. Is there any reason for such a sudden surge? The audit has helped you recruit more patients. On page 24 in phase 1, we wanted to reach elderly people who have not received any major medical services and who live alone. So through community networks, we'd like to get in touch with such elderly people first. And then we realized that the enrollment was taken up very slowly. So phase 2 began from January 2014. All the eligible elderly people could receive the services. We worked with the NGOs that provide the services. We've done a review to analyze what channels may be more effective in reaching out to the eligible elderly in the community. After a few months of work, we're able to attract more people to enroll, and right now the figure is 5,000. 9 NGOs are included in this scheme. One of them only filled 89 vacancies among 1,000. Any improvement concerning their performance? That one started in July, only 89 people enrolled, and by December the number has jumped to 664. So percentage is 66.4%. Compared to the situation in July, all the service providers have high level of enrollment. Now the average participation rate is 50.2%. If you refer to 2.30, the NGOs have done assessment on the low enrollment, and the reasons for low enrollment are included in ABCD. Some elderly people think they are in good health. Some are afraid of the assessment, that it may reveal some problems. Some are aged below 70 and therefore not eligible. Some prefer to go to nearby public clinics. These are the reasons for low enrollment. But at the same time, we're going to look at other figures for waiting list, for example, in Table 2. Because of all these reasons, perhaps those who should go through comprehensive assessment, the number of such elderly people may go beyond what is reflected in Table 2. So elderly health risk, or the potential risk, is much more serious than what is reflected in Table 2. Is that understanding correct? We don't have the figures, but we encourage elderly people to receive more health assessments. So those who are willing to queue up, so many in Table 2. If we also include those who are afraid that assessments may reveal health problems, the real figure in the community may be much bigger. But I do not have such figure. But through NGOs, we do publicize and educate elderly people at the community level to enhance their awareness of health and self-care capability. I think that is only one example in one area. The purpose of inquiry this morning, by combining the purpose of the audit's reports, it seems that the administration does not have comprehensive understanding of elderly health needs in Hong Kong. And the Secretary has said repeatedly that she doesn't know. You talked about allocating resources and redeployment of manpower. I give you this opportunity to tell us if this is one of the major challenges for your strategic assessment work. Well, we have been going for almost 2 hours. Perhaps we can go back to 2.18. A, B, C, and D. So the Secretary or the Director can tell us how they will respond to the recommendations, because all these cover what we have been asking in the past 2 hours. Then we can proceed to writing our report and then follow up on these measures proposed by the audit. So, the Director of Health, can you reply to Paul's question under 2.18 A, B, C, and D? Yes, I agree. To be fair, perhaps the questions sometimes are too wide in scope and it's difficult to answer. If you want us to, or if you want to provide a consolidated reply after collecting more information, that is also okay. Secretary, can you tell us under 2.18 the 4 recommendations how you are going to respond? You don't have the resources. You only have 123 million on EHCs. Are you going to add to that? Will you add more manpower? Can you provide your response under 2.18? I just want to limit the scope to the scope of the report. I will ask the Director of Health to respond. Director? Together with our colleague, concerning waiting time for each EHCs, number of people on the list, people returning for subsequent assessments, and treatment sessions, there will be detailed analysis and see if we can make adjustments to the different items in the morning and in the afternoon. When it comes to the growth of elderly population, the model of the EHC fails to satisfy all the elderly people. That is the fact. But we would like to use this model as an example. The other example is family medicine and family doctors to provide services to the elderly. So all these are relevant. Can you go through them one by one? A, B, C, and D. Are you going to set a timetable? Or you're going to wait 1 year or 2 years for different items, or for Wenchai and Yaomate, people have to wait for 9.5 years. So can you respond to A, B, C, and D respectively? And then we will draw our own conclusion.
With respect to B, you have promised to do it. How are you going to do it? It's about the waiting time for first-time assessment and subsequent assessments. Every center would look at the sessions offered, and we look at how the two new teams, two clinical teams, will be deployed. Whether they should offer outreach services to centers with longer waiting time. Well, there's a suggestion, a recommendation for setting a performance pledge. Is it going to be 9 years, 8 years, 7 years? How are you going to set the pledge? We'll look at how many additional sessions can be handled by the additional manpower, and then we can consider doing this. When are you going to make a decision? The additional manpower will be available in 2015 and 16. Well, you know that the report of the PAC is not the end of the matter. We'll continue to follow up the matter. We think that in 2015 and 16, after the 2 additional clinical teams are deployed, we'll then have a look at whether to set performance pledge for the waiting time. So it's 2016. What about C? It's $123 million that you have allocated for this. Are you going to increase this or not? Well, we have talked about additional manpower, not just manpower. But what about financial provision? $123 million, is it a fixed sum? We need to follow up on this. Secretary, Chairman, the Director of Audit's recommendation is to assist the EHCs to allocate their resources. We have already mentioned that in different EHCs or among the EHCs, there may be disparity in service needs, and we may need to be more flexible. The director has said that in each center there's a doctor. If the doctor in a EHC with shorter waiting time is deployed to another one with a longer waiting time, then the first EHC will be with no doctor to provide service. But there will be 2 additional teams in the coming future, and the director would deploy them to the EHCs with longer waiting times. Well, I'm not trying to teach you how to respond. I'm just asking for a response. This is a value for money audit. You have $123 million, and you have to deploy the resources in some way. I can't teach you how to answer our questions. I just want to get some answers from you. We're going to take follow-up action month after month and year after year.
明白咧，我哋明白。
我哋嗰啲資源咧，除咗係話一
Apart from the $100 million, we can, of course, try to do some allocation. More importantly, we're talking about 1 doctor and 1 nurse in a district. If a doctor is redeployed to another district, then the first district will have no doctor there to serve the clients. In the coming 2 years, we are going to have 2 additional new teams. Sorry, maybe I haven't made myself clear. I'm not asking you to teach me how to give you an answer. We are going to, what I'm saying is that we are going to adopt a focused approach. We'll deploy the 2 teams to the district or districts with bigger needs or with longer waiting times, so as to sort of even out the waiting time among districts. But about D, subparagraph D, you have promised to take action. I just want to put down in our report the clear answers I've got from you. You are going to tie in with the audit's recommendations, but the question is how. Well, we're going to have annual statistics reviewed, and in 2015 we would keep monthly statistics for each EHC. In the past, we only kept annual statistics. Thank you, Chairman, for rephrasing my question in a focused manner. If we are talking about a private organization with a number of branches, if the disparity of waiting time is 9 years and then the lowest waiting time is 1 year, well, you would try to deploy the doctor or ask the clients to go to a nearby center. For example, it's not far away, Causeway Bay is not far away from Pt1. That's better than asking the clients to wait for a long time. We have secured additional resources, as I've said. With that, we would devote the new resources to the districts with bigger needs or longer waiting time, and then we'll take another look after that on the waiting time and decide what to do next. Thank you, Secretary. You may have additional doctors or teams, but you still cannot address the big disparity of waiting time. Maybe you should try to either move the needs or the service in a flexible manner. I'm not asking you to provide additional doctors to all the 18 districts. Maybe there should be more than one approach to address the problem. If we act in accordance with the suggestion, and that is some of the time of the doctor in a district will be spent to address the needs in another district. I have to stress that we are in the public sector. We are not private medical practitioners. If we just redeploy resources from one district to another without increasing the resources, and if we want to adopt an egalitarian philosophy, that is, we want to even out the waiting time, and I may have to consider the suggestion. If no new resources can be provided, I may have no choice but to accept the suggestion. But since we have new resources, I think I will accept the approach suggested by the Director of Health and see how it would achieve. We're just here to explore the ways and means to address the problem. Well, I know this is a public sector system, and you have to abide by rules. You have two new teams. So where should they be deployed? There are more than 2 districts with longer waiting time. I'm not saying that every district should be absolutely equal on this. So perhaps you can be even more flexible for new resources. Yes, with new resources we can be more flexible because the additional teams will not affect the setup of one doctor for each EHC. So they can provide 2 sessions in one district. The new teams can provide 2 sessions in one district and 3 sections in another. That can be arranged flexibly. In some districts, the waiting time is relatively shorter. It doesn't mean that the clients don't have to wait. If I live there, I will not accept redeployment of the only doctor in the EHC to another one just because my waiting time is shorter. If we cannot secure new resources in any way, then I might be forced to consider Mr. Chair's suggestion. But since we have new resources, that will not be my first option. Well, we know that clearly. You are clear about this from your perspective. But we have to seek elucidation so that we understand it perfectly. We have to write a report. We have to explain to the public. We have to explain it to the people waiting. I know what you are trying to say. Well, people, according to you, some people have other choices. But for the most of them, these elderly people may have no financial means, and they have to rely on your services. And we have to be fair to everyone. I'm not saying that everyone should get the same service level, but there are certainly problems in some districts. So the administration must look at how we can handle the situation we are in. Because for those who cannot get the service, they may have no alternative. And according to Chapter 1 of the report, some of them have been waiting for care and attention home, and annually 5,000 odd of them die while waiting to be allocated a place. So we do want to make sure that they have a better understanding of their physical problems, physical conditions. Well, we have completed the hearing on Chapter 1. So now we want to make sure that all the needy elderly would get assessment properly. I know you have to handle resources, but this audit is on value for money. We need to understand the problems that you have, and we need to explain things to the public. Well, I understand that, but I beg to differ in respect of the problems identified in the first chapter, in Chapter 1. Returning to this chapter, if we were unable to secure new resources, then I might be forced to consider Mr. Chair's suggestion. But since we have secured new resources, then I would say that we should allow the director to deploy the new resources to the needy areas, and then we can review the outcome later. All right, if we look at Table 2, even for the district with the shortest waiting time, that is Yuen Long. For Yuen Long, they conducted 332 first-time assessments annually, and the number of people waiting for first-time assessments 331 now on the waiting list, and the waiting time is 1 year. And of course, the new teams will not go to Yunnan in the first instance. But is the waiting time of 1 year acceptable? We were on 2.18, and you, Secretary, you are not willing to tell us whether you would consider setting a performance pledge for first-time assessments. It's important to have a pledge, in my view. If I say that a first-time health assessment should have a waiting time of no more than, say, 6 months. From what we have heard today, there are a few ways to achieve this. First, you may say that this is not the full picture. The waiting time doesn't reflect the full picture. For example, in Yamate, there are 2,079 elderly waiting for assessments, but 1,800 have already got served in the private sector. And then you can give us figures. You can quantify the extent of the problem, and then through public-private collaboration, and there will be timetable to develop this. And then you can tell us that after 2 to 3 years, you may say that the performance pledge of 6 months of waiting time can be achieved. You may have additional teams, or you may make the best use of PM sessions. There's spare capacity as indicated by Table 5. If I work in Shakuhoi, I will be very busy. 33 treatments, 33 cases were handled. If I work in Yunnan, it's just 16. It's just half of the workload of Shakuhoi. So maybe some reallocation can be done. For example, you can ask the elderly clients of Shakuhoi as to whether they would be willing to go to Yunnan. And then you with a performance pledge, you can explain the alternatives to people. Of course, it's alarming. It's really frightening to have a waiting time of 9.6 years. But let's not put the cart before the horse. The Director of Health has said that let's wait and see how the 2 additional teams can achieve. But if you don't change the parameters of your service, then even if you get another 100 teams, you are not able to improve things a lot. You need to have a performance pledge first, and then you can explain to us and to the elderly that actually the waiting time is not 9.5 years. You get the service in 6 months. That's my understanding from the information we've got today. Maybe the Secretary would care to respond. We're talking about 2.18b, right? Explore the feasibility of setting a performance pledge for the waiting time for the elderly who wish to enroll for EHC membership and first-time health assessment. We can promise to do this. You can give us the answer in 2016? I don't have any timetable. I agree to explore the feasibility. Well, your director has answered my question. They would check the progress, and answer will be available in 2016. Can you give us the answer in 2016? The director says so, that the answer will be made available in 2016. maybe the director would care to explain why I said that we have got 2 new teams to be formed in 2015 and 2016. When the 2 teams are formed and in place, we can certainly explore the feasibility of setting a performance stretch for the waiting time. In 2016, they will be working already. We can do that then.
希望你睇睇。
Thank you, Director. Secretary, I hope that you would base your answer on the report. If you think the report is not accurate, do take this opportunity and tell us. Because in 2.19, Director agrees with all the recommendations in 2.18. And at this meeting, we are just asking in relation to 2.18b whether a timetable can be given, because we did not force her to give an answer. This is what's written in the report. So when the Director of Audit submitted this report to you, if you disagreed, you could tell us. And please let me finish, Secretary. I have ample time. I'll give you time to answer. But we need to have sufficient information for our report. If this is not something you can do, then please don't give this undertaking, because we're just following this audit report. So, Director of Audit, did you let Director or Secretary read the report before putting down 2.19? Yes, 2.18b was the issue to be explored when we discussed with the Director of Health, and we hope that after exploring the feasibility, a conclusion can be drawn, a pledge may be given with a timetable. So please understand, Secretary, that we didn't write the report. It's the Director of Audit who wrote the report with your subsequent agreement, that we followed up on this report. Chairman, like I said just now, with new resources, we anticipate that in 2 years' time we can explore the feasibility. So I agree to that. So what didn't you agree to just now, Secretary? Well, perhaps I misunderstood that someone suggested that I should give a timetable for a performance pledge to be made. Well, a number of members have spoken. I'm sorry. It's all contained in the Hansard, Secretary. I want to clarify that just now I said I couldn't give a timetable because I misunderstood that somebody had asked me to give a timetable for making a performance pledge. Yes, it was me. I gave an example. I said 6 months. I want to point out, Secretary, that if you don't have a performance pledge, you don't have a goal, and if you're not goal-oriented, it's difficult to get anything done. That's why I asked Secretary whether you would consider setting a timetable for a performance pledge for first-time health assessment for the elderly. We have performance pledges for different departments, for the judiciary, for post office. That's why we ask whether you have a performance pledge. It's impossible to set it at 9.5 years. I don't want to repeat myself, but to conclude from the evidence I heard, if you want a performance pledge, make one, and then you can build up a database, and then you can explain that the figures in Table 2 presents the transitional period. And you can also explain how you can how you can deploy spare capacity, say in Shek Wu Hui, to deal with other areas. So my answer, the answer I heard is that Secretary is unable to give a performance pledge. That's the answer I got. But in para 2.19, I don't think I can accept this. So we need to be clear, because in 2.19 of the report, they agree to give a pledge. Now, Chairman, let's learn the bureaucratic language. It says explore the feasibility of setting a performance pledge. And then in 2016, they'd be able to come up with an outcome of their exploration of the feasibility. So I make my position clear as a member of the PAC. I don't accept it, because without the performance pledge, you don't have any goal or objective. You can't implement your initiative with this objective in mind, even if you improve your database to accurately reflect the situation. And to say that Table 2 is an exaggeration of patients waiting for assessments conducted by EHCs, you need to have a performance pledge in order to do that. The Chief Executive puts people first. Elderly people have been waiting for 9 years, and we're just asking you to give a performance pledge, and yet you tell us that you can't decide to make that pledge until 2016. So my question is, I'm not teaching you, or giving you a lesson, but is this government really giving people first, or putting people first? Elderly people have worked hard to bring us prosperity in this generation. So can you give this undertaking that you can give a pledge, a performance pledge, to give the services elderly people need? Secretary, you are a medical doctor as well. You can choose not to answer. In fact, you've answered, Secretary. Chairman, I think I need to make my position clear here. I fully agree with the spirit that we should put people first. With the resources we manage to strive for, we aim at enhancing our efficiency, especially when the Director Audit is looking into the issue of efficiency and this exercise. And with existing resources, we try to meet the public's needs. And I fully agree with the spirit. But I must say that the PAC meeting is a solemn and important occasion. If I am not 100% sure that this is something I can do, I'm afraid I cannot give this undertaking here. If I don't know whether I have the resources to implement this, I'm sorry, I cannot give this undertaking. Chairman, we're not asking you to give an undertaking. We're just reflecting social problems to you, because it's not this committee which accepted the audit recommendations. It's the Director of Health who agrees with the audit recommendations, and we're just following up on the audit recommendations. We're empowered under Article 73 of Basic Law to monitor the administration in the use of public funds. And the Audit Commission conducts value for money audits. You spend $123 million on EHCs, and that's the perspective we take. Indeed, some, not all, but some have waited for 9 years for a health assessment. And this is hardly acceptable. If you say it's difficult then so be it. We'll put it down in the report. It's up to you. I think by this time we can write our report on part 2. I don't think we should further waste time. You've given your answers, and it's up to us to decide how our report should be written. I don't know if we agree to that. If so, we'll take a 15-minute break.